Good morning, everyone. Thank you for joining us. I'm Dr. Judy Monroe. I'm President and CEO of the CDC Foundation, and we're very pleased that the CDC Foundation is able to bring you this morning this important discussion about the symbiotic relationship between public health and business. In this discussion, we'll be talking about how we need to create partnerships that can keep our communities safe, our businesses strong, and establish a foundation for keeping America's economy robust. The CDC Foundation, if you're not familiar with us, we were created by Congress in the 1990s as an independent nonprofit, and our charge is to create public-private partnerships to help forge the CDC's mission, and really to keep health threats and health safety for Americans. So the foundation tackles health challenges ranging from infectious diseases like malaria and tuberculosis to chronic diseases like cardiovascular disease and mental health, the opioid crisis as an example, and emergencies such as Ebola. So I'm grateful to Elizabeth Cohen for moderating this discussion. Elizabeth has been bringing all of us information about important health topics for many years. Here in the United States, we do focus a lot on healthcare, which is critically important. However, as a physician and a former state health officer, I know that public health is where we have the opportunity for the greatest impact. And that's because public health is about every person in every community, in every corner of the nation, every day. So disease prevention is, if we want really a strong economy, right, we want to prevent and we want to control and save lives and money. So investing in public health leads to early detection and containment of outbreaks and other significant health challenges, preventing widespread illness and loss of life. It is the most efficient and effective use of tax dollars, in my opinion, and has the biggest impact on the most people, as well as on creating healthy businesses and a healthy economy. So we need to come together at the local, state, and national levels to bolster public health. The workforce, we need to modernize data systems, invest in our laboratories, and our response capabilities. So that's why it's critical that public health and business partner together to address the deadliest and the most costly health challenges that we face as a nation and a world. So with that, I'll turn to Elizabeth and our panel. Thank you.
Judy, thank you so much, and welcome everybody, and good morning. What a lovely morning after the rains of last night to all be together and talk about this important topic. And I'm so honored to be joined by these three wonderful physicians. Introducing everyone, in the center we have Dr. Mandy Cohen, the director of the U.S. Centers for Disease Control and Prevention. And to my left is Larry Bouchon, who's a Republican congressman from Indiana, and Ethan Burke. I almost said Ethan Hawke. The other people
I know. Easily confused.
I don't know why I almost did that. But Ethan Burke, who is Senior VP and Chief Public Health Officer at Optum Health. So, Mandy, let's start with you. Why do business and public health need to work together? I mean, I could see someone thinking, you've got a multi-gazillion dollar budget. Why do you need, well, maybe not that high, but, pretty high. And why do you need the private sector to work with you?
Well, so first I'd say, great to be here. Thank you to the CDC Foundation for hosting this important conversation. I think we all saw how public health, or frankly, a virus, can turn our lives and our economy upside down. And so we know that good public health is good for business. And so I think a really important conversation, but we also know that the mission of public health to protect health and improve lives is big. That is a big mission, and it cannot be done alone from CDC, or even if CDC partnered with just traditional public health entities. This has to be a team sport as we think about protecting health and improving lives across the country. And I'm so thrilled that Congressman Bouchon, who has been a leader in thinking about these issues, is here to join us for the conversation. And then we have Dr. Burke from, we're going to do first names after this, though, from one of the largest healthcare companies thinking on the delivery system side, because I think this partnership is really, really critical if we're going to protect our country from emerging health threats, from existing health threats, and if we're really going to think about being the strongest country we possibly can be, both from a health perspective, but also from an economic perspective.
So we're going to talk later about sort of the dream of what a public-private health partnership could look like. Can you talk about anything right now that the CDC is partnering with the private sector on that has gone well, that you're proud of, before your tenure, during your tenure?
Yeah, well, absolutely. We are constantly in partnership. I do want to step back and say during the pandemic, when I was leading in North Carolina, I saw so much collaboration that allowed us, particularly in North Carolina, I think, to be successful. I saw major hospital systems that are usually competitors come together and say, how do we solve problems together? I saw folks in the private sector who turned their supply chains into helping us think about PPE or vaccine delivery. It was incredible to see my folks in the Chamber of Commerce be side by side with our education partners, with public health. And the question now, as we are in peacetime, if you will, so happy to be outside of that emergency, well, what is the right way to retain those relationships that we built? What is the right way to make sure that we are prepared going forward into the future and that we're all doing what we need to from our different roles and responsibilities? So from the CDC, we partner in so many different ways, whether it's, I'll start with the health delivery system and then I'll get to the rest of the business community. But on the health delivery system, we absolutely have to have a partnership. So when someone is sick with measles or avian flu, they're walking into doctor's offices and emergency rooms, right? Maybe one of Optum's. And we need to make sure that data is getting captured there, but sharing so that we can have a picture of what's going on so we can be able to respond. So we're already in partnership on a data front. We're in partnership on innovation around diagnostics and therapeutics. And we're in partnership as we think about delivering vaccines, right? Vaccine saves lives, but the folks who are doing a lot of the administering of vaccines are folks in the delivery system. So partnership every day. But on the business side, of course, the businesses are the ones that offer their employees health insurance, right? And are keeping their employees and thinking about a productive workforce. So already, I know employers are doing things like offering flu shot clinics. They have been for a while, thank you so much. But as we've seen a new emerging threat like COVID, I hope those same employers are going to be offering flu and COVID shots come this fall. So I think there's a lot that the business community can do and is already doing, and I look forward to further partnership.
And Larry, do you have any examples in your state of some great private-public cooperation in this area?
Well, yeah, starting in year 2020, Indiana University came out with a study that, and you can reference this on the internet, that showed a direct connection between economic prosperity and public health and a healthy public. So with that, Governor Holcomb's administration then developed a commission that combined state government with private sector entities across the state to look at this, to try to come together and say, okay, what can we do together? Because we have direct information that economic prosperity has a direct link to public health, and it's in everybody's vested interest. And out of that came a number of things. One of the biggest things, a 1,500% increase in state funding for the state public health system, which we had recognized also during COVID was really underfunded and understaffed and had been for many years. So, I don't have any specific industries or companies that work directly, but on this commission, there were people from the private sector working with government officials, and they all came to the conclusion that we needed more funding, we needed to up our game as it relates to public health, starting right at the local level, at the county level, all the way to the state level. And those decisions were made in combination with government and the private sector. And so the other thing is they've also, and I know we'll talk about data later, but also recognized that we had to have good data from all of our counties, and I think Indiana is one of the first states that actually has put as kind of almost a central repository for data that's doesn't go to this agency, some go over here. It still does that, but there's a way to more centrally evaluate data, and most of the counties in our state participated in that, and that also partially came out of this discussion with the private sector and the government combining on this commission.
Great, thank you. And
One thing, as we talk about business and public health today, I think it's important to differentiate two different pieces to this. One are the health businesses, and what's the role like my company plays. And we have a couple examples I could share where we've done work with CDC as well as with the CDC Foundation over the years. The second is all businesses. And businesses are in the community. They're the primary economic driver. Sometimes in a small town, there might be one large factory that's the primary employer of the town. That's a public health opportunity as well. So it's not just the health industry as a public-private partnership. I think any industry has an opportunity to do public-private partnership because that's our opportunity to amplify the message from CDC, from state and local health departments, tribal health departments, into a trusted part of the community. On the health side, I think COVID, we all learned a lot and worked together, and I think one of the most exciting ones that we did with CDC, FDA, Gates Foundation, University of Washington, was UHG physicians in Seattle and in Minneapolis developed, with that partnership group, the self-administered COVID tests and the validation work that we were able to very quickly give to public agencies to make the right policy decisions and figure out how to incorporate that into plans.
tell me more about that. So how did that come about, and what exactly did United do?
So in the early days of the pandemic, we're the largest primary care system in the United States. Seattle was one of the early hotspots of COVID, if you all remember. Actually, I think it started well, not started, but one of the early cases was in a nursing home. Yep. We very quickly were starting to run out of personal protective equipment and PPE, and for a health system or a clinic or a provider to have to gown up to do every COVID test wasn't sustainable at a national level. And we had many, many phone calls with CDC and other federal agencies, the White House, about how are we going to get in front of this? What can we do as a company very quickly because of our reach and our funds and our scale where we can act fast in partnership with others, and started to do the initial validation work with a self-collected swab, an oral swab, a professionally collected swab, saliva samples. University of Washington and the Gates Foundation were really key partners in that work. And we were able to take that data in 10 days with hundreds and hundreds of patients of experience and start to get that early information to the public sector to be able to make the decisions for the nation on how we should proceed. And it was a way for us initially to reduce the amount of PPE we're using. Now it's incredibly convenient, and I can't imagine not doing my own COVID test.
Because it's so fun.
Oh, it's super fun. Yeah.
No, it is hard to imagine. So it sounds like this was not, you didn't get a contract from the CDC and do all the paperwork and da-da-da-da. It sounds like that was not this.
No, and I think you said it before, everybody pitched in because we all had to do the right thing. And companies that had never worked together before, or might be competitors, government agencies where we were always a little tense about public-private relationships in the past, realized that there's strength in coming together because we each bring a different piece to the plan.
And Mandy, is that an issue? I know folks from the CDC have said that if you want to sort of do a new initiative, the budget lines are very inflexible. And so is it in this situation, you just had to do it and it got done quickly. But do things always work that quickly?
Well, I think there's two very different kinds of partnerships that I want to make sure we're talking about. One is where we may have a financial or an official relationship with folks. One I can think of outside of COVID is in our MPOX work. There was a laboratory developed test that we'd had at CDC, but we needed scale. We needed to get that out to everyone. We have public health labs that have it, but we know that people are walking into primary care clinics or emergency rooms, and we were able to transfer that technology asset to commercial labs. So that was a formal relationship and partnership. We're able to do that more quickly. We're doing that now actually in conversation with labs on avian flu and scaling up that assay into commercial labs right now. So those are more formal relationship. But then there's just a lot of work where we're all trying to make our communities healthier. right? And where we're trying to protect health and improve lives. And what are the ways in which we can prioritize together, share data together so we all know what problem we're solving together, and how do we think about roles and responsibilities? That doesn't mean we have to have a financial relationship together, but it is about how do we have aligned investment. So where CDC may say, hey, we're investing in work to reduce suicides. Here's how we are putting our investment. Here's the data we can bring. But you know what? Optum, I really could use your help in helping us with some data visibility. Or we're seeing best practices at connecting people to care at a time of a non-fatal overdose. How do we think about implementing that in your networks so we can bring the evidence, but they can bring the scale? And again, without a financial relationship. And I think both are really, really critical.
And Larry, you mentioned a data kind of sharing agreement in Indiana. Can you tell us a little bit more about that?
Well, I mean, we've got participation from all of our local counties to get that data to the state government, but in a form that is usable, right? Instead of being able to basically knowing which phone number to call and getting that data. And of course, when you have that data, then the state hopefully at some point can then share that type of information with the CDC to get a more national data. But that's been a challenge. I'm in politics, so I had legislation called HR 550, which was a legislation in the House meant to try to improve that data collection, de-identified data collection, to go from this state level, which was in a usable form, and make that more available to what's, in real time, what's happening, so that the CDC can help analyze this data, whether it was on COVID or whether it's on, some other outbreak or public health in general. And so I think mostly what we've done in Indiana is made it so that it can be more effectively evaluated, and it's not this disjointed, different
And how might the
information.
private sector be able to help with that?
Well, I mean, I think this is primarily what I'm talking about on the data side of a governmental agency. But let me just say, the private sector has a vested interest in public health. And I think Dr. Cohen has outlined very well about what the CDC does. But I do think that, the private sector can, in some way, encourage the people that work for them to participate in the system, so that they can so that they're not afraid to have their information, congealed in a de-identified way in a public entity. That was one of our biggest challenges during COVID that we saw, particularly in Indiana, is where people were very reluctant to participate and agree to have some of their information, even de-identified, collected, so to speak, by the government, because there was just a fear of that being a database that would be used against people if they decided, for example, and it's their constitutional right to decide what they do with their own health, if they decided not to get vaccinated, for example. So the private sector can encourage the people that work for them through good information about what the government is doing, whether that's state or the federal government, and why. And so people have a better understanding about the importance of the information. And I think, that's the best way. I mean, I know that's not a specific answer, but every business has a vested interest in the people that work for them being healthy. Because, again, the IU study and others, multitude of studies out there have shown there's a direct connection between economic prosperity and the health of a population. If you're a very unhealthy population, then you're going to have people who can't participate in the workforce, that have all kinds of other issues, that have high medical costs, that will affect the economic prosperity.
Well, and I want to thank Larry for his leadership on the bill he was talking about that would have given CDC additional tools and authorities to, again, collect de-identified data so we can respond better. That didn't get over the finish line, and so we are trying to make progress within the authorities that we have. And so what I would say for private sector, we are certainly working with all of our hospital systems, with clinics, to be able to submit us electronic case reports. So, for example, something, and and I'd love, Ethan, for you to jump in on how's Optum doing on getting us those? We could use some more.
Let her know, Ethan.
And so, but there's been like a number, I want to shout out to a number of very large FQHCs in addition to some big hospital systems that are already submitting electronically case reports. So if someone has measles, right, we want to know about it so that we can make sure we're connecting dots between maybe someone walks into one emergency room, but then they walk into a second case walks into an emergency room across town. Right, having that de-identified data to say, okay, are these cases linked? Do we need to do more investigation? And doing it quickly can prevent a larger outbreak. And so we want to make sure we're getting electronic submission of that data in a way that allows public health to respond both at the state level and then also for us to have that national picture.
And those case reports go to the CDC or to a state health department,
Both.
then to the CDC?
Both.
And how long has that been going on?
So we're in the process of doing that. That is a big effort that we're underway in 2024. That was not happening at all before the pandemic. We focused first on data from our emergency rooms and making sure we can get real-time data. And the good news there is we have real-time data from 90% of the emergency rooms, right? That's a major private-public partnership right there. So right now we are able to get that real-time data and visibility. Now, but we need more specificity to make sure, again, we're responding to individual kinds of diseases. So we want to get those electronic case reports as well. So that's, and we don't, I want your help, but we don't need your help for this right now. We can make
That's
progress.
good, because it takes us
So,
forever to do it.
Ethan, but right, because Ethan can say.
Let's put Ethan on the hot seat. Ethan, how are you doing with all this?
How are we doing?
I think we're actually doing pretty well, but we have, but we have the challenges too. I mean, we're large and we have a lot of data, obviously, and some of it's very low latency, very fast data. And we're working with you all on those early warning signals. But there's a challenge across U.S. healthcare that there's a million different medical record systems, there's a million different payers, and how do we get it to you all in a useful way? Not eventually, but I think the speed is the piece that has been really critical as well. There's two issues that pop up in my head in this part of the conversation is that there's not public health data and hospital data when you're thinking about this, there's just health data. And the way we've kind of created the whole schism thing that everybody always talks about between medical health and public health is kind of nonsense, and we need to think of a way, if we're really going to understand what's happening in a population, particularly with early warning, the next pandemic that might be appearing or whatever it might be, how do we start to see this as a unified data set that is a continuum from public health all the way through to the kind of care that you used to provide? The second issue is trust, and there's trust at the level of the individual or family in sharing their data. There's also trust at the level of the hospital sharing their data with other entities. Are they going to get in trouble? Is their quality report going to go down? What's the give and the get equation for everybody involved in data sharing? If I give you my data as an individual, how do I know that this is useful for me or useful for my family or my community? How do I know that it's being used in a good way? If I'm a hospital or if I'm United Health Group and I work with CDC on giving data, how do I know that this is advancing our shared mission of health? And I think sometimes we ask for a lot in healthcare, and as a family doc, I ask a lot of questions. I'm not sure we always do a great job of the why we're asking or how we give it back to people. And I think we're getting better at that. I think we learned that lesson from COVID, and that makes it easier then to, the technical stuff still has to be solved, but the trust issues I think are so key to this type of data sharing across a continuum of health data.
Do you mean that United or hospital might be concerned that it's not advancing your purposes, or you mean the individual patients are concerned, or both?
I think it's both.
Okay.
Yeah, I'm curious what you guys think, but I think individuals, or families might not want to share their data.
But if it's anonymized, why do they care?
But they do. I mean, we see that. Is it that what's the government doing with my data? Is it truly anonymous or is it not? That's a hard concept to understand.
But I would also say, and I want to say, we've made a lot of advancements on the public health side to make it easier to share data because, sharing data is not a free exercise. There's burden there. We recognize that, and I think the work we've been doing, particularly in the last year on the public health side, is to align with the data standards that are happening already in the health delivery side. So we are hoping to leapfrog over and adopt things like TEFCA, not to get too much into the weeds, but like TEFCA and fire standards, and to make sure that public health isn't doing something different than what we're already asking for in the health delivery space. So there's a lot of work for alignment there, which I think reduces burden and allows organizations to say, okay, I understand where my data is going. I also think public health, we need to get better at sharing back.
Yes.
We ask for a lot, and we need to give back.
What do you have that Ethan might want?
Well, so, right, I think that different hospital systems want a view of what's going on in their community. Some hospitals are the only game in town, but most places they're not. But they can operate and respond better if they know what's happening in their community. And I don't think hospital data is the only data out there. I also want to say that there's laboratory data, there's wastewater data, there's data from education, so, right, what's happening in our school systems, right? So we're focused on healthcare because I think that's a place where we have to, align. We all speak the same language, but I don't want to stop there. So we have a lot of, work to do, but I see a really good glide path for where we're headed.
Look at the work you're doing on climate.
So
And the heat index maps, the contextual data is so important for public health.
Tell me more about that.
Well, I mean, now we might be eking into the social determinants of health conversation, but it's not just your health, it's your education. Do you have housing? Are you eating healthy food? Dan Buettner was here.
But I mean, the sharing part of that, how does that relate with sharing between private organizations like yours?
Well, I think it's us giving data back to the delivery systems to say, hey, it's not just temperature, there's actually real risk with heat in different parts of the country. Mm-hmm. And when you see it, here's some clinical information and things you should do different clinically. Mm-hmm. And so that's, I think, the value add that we can give back from CDC side, right? When we're seeing data, we get that from the hospital system, again, de-identified, we can analyze that and say, look, this is what we can feed back to you to better help your patients that might be experiencing serious.
And a great example of that is America's Health Rankings, which has been around with United Health Group and CDC and I think the Foundation for a long time, where we're benefiting from CDC data, processing it in a way that's actionable for communities at that community level in a way that's maybe more approachable or more reachable than a heavier scientific type approach of that data. So I do think it's a really symbiotic relationship.
So you had mentioned before, Ethan, that you want to make sure that when you're sharing that it's promoting the sorts of things that the patients would want to have happen and the sorts of things that United would want to have happen. So what would be United's concerns might not be the right word, but what would be United's concerns in sharing data? Like, what is it, because that it might be very burdensome and you might have to devote a lot of staff and a lot of hours to it, or are you concerned that a competitor might see something you don't want them to see? Like, what are any of the impediments to sharing?
Well, I think, as Dr. Cohen said, data sharing isn't free, and there's a huge
Right.
cost.
What's the cost to United? I guess that's what I'm getting at.
Well, we have the cost to us in terms of
sharing, like if you get asked to share XYZ, what is the cost, what is the burden for you to share? Like if I was going to share my pen with Larry, I'd just go, here, Larry, here's my pen.
Yeah.
But I think it sounds like, you don't feel like that.
that's it right there. That's the problem. It's a very complicated answer. I think some of it is the data use agreements that we are under. So for instance, we can't to commingle data from one state's Medicaid program with another state Medicaid program to create a universal Medicaid data set, because we have agreements of privacy and protection, and the states own the data. So we're not necessarily in full, we're not always autonomous in how we can control and combine the data either. We have to be very careful about who owns it and those patient rights, an employer's right, a state's rights, and then figure out how to use it in a way that's still data protected for the greater good. But a lot of it is technical.
I think the technology exists. There's a lot of governance issues that I think are at play.
For sure.
Can I make one comment also
Please.
on the data itself? I think everyone needs to recognize we've been collecting data for decades on all kinds of things. Where do you think like the childhood immunization numbers come from when you look at a national map? from a political perspective, what happened with and why we needed to do better, don't get me wrong, for quick moving things like COVID. But it got very politicized, and a lot of people failed to realize we've been doing this, but we need to do it better. And we did find with COVID that there were gaps in the system, primarily at the local, I think, and state level as far as it relates to quality data. But I try to get across to some of my colleagues and also to my constituents that this has been a very important part of public health, good data, for decades. And so we have to figure out how to do this in a way that makes people want to have their data de-identified, shared in the effort to overall create a healthier society that we live in. And again, as I mentioned earlier, there's a direct economic impact on that. So that's the other thing. Remember, we've been, in many respects, analyzing data for decades. It just became, I think, overly politicized during COVID, and that has made it more difficult to what I'll say is reform, like with HR 550, the way that we can make sure that people like the CDC can have this good data to really help not only us, but help everybody else in the world.
And Mandy, as you've asked different private entities to share data or whatever else, is one of the impediments, these are competing entities often, right? We're not in Europe, these are competing entities. Do you see hesitation like, oh, wait a minute, if I share this with you, it might give a competitive edge?
Absolutely. I'll go back to my praise of our hospital systems in North Carolina during COVID, where I saw cohesion amongst competitors, and understandably, and data allows them to have competitive advantages. So the question is, how do we overcome that? Now, we have rules and regulations from the CMS side about interoperability and the importance of it, and I think that's where the partnership with lawmakers and making sure that we're helping folks understand the privacy side, I think we can make a lot of progress here. But in recognizing that there are entities like our big hospital systems that are caring for large communities, but that data is a national asset. That is a national asset to protect this.
It's a national asset not owned by the nation.
That we need to make sure is visible for the nation in order for us to do our job to respond and protect health.
And so in my sort of Pollyanna-ish mind, you go to one of these large hospitals and say, this is a national asset, it's going to help everyone, please share, that they'd say, sure, why not? But is that the way it works, or am I really being a Pollyanna?
So I think there is an interest in sharing, but we want questions to be answered. How is the data going to be made sure that it's private? And I think those are right questions to ask. How is this data going to be used? What value, if I'm going to put in the work on the health system side, what value am I going to get back? I think those are all right questions. We're having that now, and progress is being made is sort of the message, I think, but we need to make faster progress, and this is really important and underlies all of this private-public partnership, because without that data, we can't know what problems to prioritize. We can't really have clarity on roles and responsibilities, so that really is the underpinning for a lot of this.
Because they're not required to share anything with you. And when I say you, I mean the public health system.
Sometimes, oh yeah, so
Sometimes
there are reportable diseases,
Okay.
right?
Oh, sure,
So
right.
think about a measles case, like that is a nationally reportable, but how do they report? How
Right, quickly,
How
or-
much burden is on the health system to report that? Into what system? This is where CDC and the public health side needs to be better in terms of making it easy to collect that data. And how do what's the timeliness of doing all of that? And to quickly look for patterns.
And at state and local health departments, and what's their data, and how does that get to the federal level too? That's highly variable by state with different levels of technology, staffing, capabilities of the people there. So that's another source of data that we could do better with as well.
And Mandy, you mentioned partnership, sort of like, I'm paraphrasing you, sort of what can you give them? What can you give them?
Well, we were having multiple conversations here at Aspen where I'm hearing folks say, hey, I use your data for different efforts. And I think we are trying to be better to make sure not only are we collecting the data, but then we are displaying that back in a usable and actionable way, that we are turning our data into action for folks much more quickly. We are making, for example, like a big investment on the opioid side where we're trying to stay ahead of what's on the street and what might be impacting folks in terms of overdoses. So how do we turn that data into action more quickly for folks? So I think there are a lot of ways in which we can offer good data that feels super actionable for folks in the moment. Health and heat was another one. So there are a lot of ways. Vaccination data. I think we need to get better at getting real-time vaccination data so we know who's not vaccinated and we can target resources in the appropriate way. So we're making progress, but more needed to be done.
And a question for any of the three of you. Jump in. If you could wave your magic wand and create any private-public health partnership that you could, I'm going to give you all the money you need, I'm going to give you all the cooperation you need, what would be a terrific partnership that could really benefit public health if you could wave a magic wand?
Why are you all looking at me?
I personally think Mandy's in the best position. No, I'm just kidding.
Well, one area I was thinking of, and I think we all could do better at it, but there's some success stories that come to mind as well, is around communications. And I think sometimes there's incredibly smart people all around. Sometimes we don't do the best job of communicating to stakeholders, whether it's Congress or the public or an employer or a family. And there are entities that are really good at communicating and understanding that talking to one person or has one identity or one set of values might need a different message about the same scientific data than another family that has, or a person that has a different identity or set of values. I think we can do a lot more refining of the messaging to make it more personable and sort of aligned to the values that are in somebody's head, so then they trust it and maybe take the actions we're hoping that they take. And that's an area where I think the right public partnerships can improve our ability to communicate. And it goes back to that scaling of trust and relationships. How do we scale trust and relationships at a national level by reaching people as individuals to believe what we're saying scientifically?
Can I go ahead, Mandy?
No, please.
Indirectly, I think the best public-private partnership at the governmental level is what are the things that the private sector is trying to do, right, in the public health space or other areas, but and you pointed out that, and there are governmental, regulatory or statutory barriers to that. And how do we work together to identify the ones that need to be in place and the ones that really probably need to be looked at and say, look, this is a barrier for us to make advances in public health, and that barrier is a high bar, and unless Congress or unless the state government of Indiana looks at that and takes down some of those barriers, then you're going to continue to have the situation that we're in, where you have a difficulty broadly cooperating. So that's the best public-private partnership I can have as a member of Congress is, tell me what are the things that in the private sector are barriers to progress. And now, I'm not for massively deregulating everything, but I want fair and appropriate regulation and statutory requirements in law that aren't barriers to progress. And that's very true in the public health space from my perspective.
So if I was to ask us to focus on three things, I've articulated in other sessions sort of what we are focused on, and I'd love the private-public partnership to help us here. One is to be ready to respond to any health threat. Again, could be infectious disease, could be something heat-related, but that we are ready to respond and we're working together. Second, we're improving mental health. And then third, that we're supporting young families. I think if we want to be the economic superpower that I know that we have the potential to be and continue to stay at the top, we have to be the healthiest that we possibly can be. And that those lifelong health patterns start when you are young. So making sure that our kids are getting vaccinated, but also that mom and dad are healthy, that we're preventing diabetes and heart disease and stopping smoking. So those are the places where if I was to say, what are the things I hope we can all align on? I think those are three really important ones. Being ready to respond to health threats, I think that is a national security imperative. Improving mental health, coming out of a crisis, we have some serious mental health challenges. And then third, to make sure if we look to the future, right, and invest now in young families so we can be the healthiest we can be. So, and the way to do that, if you're ever having trouble sleeping at night, we wrote a New England Journal piece on how to try to tackle this together, and if you're having trouble sleeping, and it has a framework for, okay, if those are the three things we want to accomplish, how do we do it? I think we've had a lot of conversation about data, which I think is really important, because if we don't have the right data infrastructure, we're not going to have the right priorities and alignment. Then we all have to think about, okay, then we have good data, then how do we have shared priorities? I articulated three. Maybe those are the ones, maybe those aren't. At the community level, let's have that shared investment together. So if the Chamber of Commerce and local public health can invest together, maybe it's in maternal mortality. Maybe it's in making sure that they're responding to avian flu because they have a huge dairy industry in their locality. And then making sure that we give clear roles and responsibilities. There are things public health absolutely should do and be excellent at and be the quarterback of, but then there are really important responsibilities for the health delivery system to do and deliver on. And there are responsibilities for our government officials. There are responsibilities for our education partners. And how do we be clear about all of those? So you can read that in the paper.
Okay, well, great. So everyone go read that paper, then we'll do audience Q&A. No,
Exactly.
I think we'll start audience Q&A now, actually. So let's see. We have, I'll let the two of you decide which one. You look like you know each other, maybe. Yeah, you do now. Okay, so either one of you. Well, one and then the other. How about that?
I'm Jennifer Jensen. I'm a public health nurse. And you talked a lot about data partnerships. I feel like at the local level, sharing data wasn't top of mind for me. It's that we're under-resourced. I thought we were going to hear about corporations, either because of corporate social responsibility or just because they know that an underfunded public health department is a problem for them too, giving medical supplies or personnel or free access to their electronic health record or other resources that they have. Is this kind of partnership happening, and can you share some examples of that?
Let me just reiterate what I said about what the state of Indiana did as it relates to this commission that looked at this more broadly, and the 1,500% increase in funding for our public health system. To your point, underfunded, understaffed, and really COVID brought that out. So at the state level in Indiana, that's been recognized. And then also as it relates to coordinating with all the counties with their local data and getting that at a statewide usable level, we've also worked on that. So I think those are the type of things that at least I can speak for the state of Indiana that has been recognized from a governmental perspective that we need to do.
Well, so I would say I think the corporate philanthropy part is important, but doesn't feel like systems and structures to me. So I want to see our not just corporate partners, but even small businesses too, thinking about the health of their workforce, right? Because they're going to get more productivity out of a healthy workforce. And what are the things that actually work to keep your workers healthy? Some of that is making sure they have good health insurance coverage and are doing the things that they need to be healthy. And how do you incentivize that as a worker? How do you incentivize vaccines? How do you incentivize smoking cessation? How do you incentivize diabetes prevention? I think there's a lot that employers, big and small, can do. And again, use CDC data, and I think we can be even better partners and want to be with the business community on that. I heard, for the first time we have a vaccine for, or an immunization for RSV for babies. And one of the things I heard from the business community, they were like, That's fantastic. And I was like, oh, because you know what? A lot of moms and dads are out of work when their kids get RSV. Right? And so I want business owners to be thinking about how do we have a more productive workforce, and mom and dad are not out sick or out of work because their kids are sick. Vaccination. And so how do we make those connection points there? I think there's a lot of opportunity for business there, and how they design their benefits, how they use public health data, and think about that. And this is also where public health needs to reach out to the business community more. I don't think we've been as good about aligning. I think the emergency put us at the same table. Let's make sure we stay at the table together.
And the person sitting next to you. Oh, okay. Let's see. Right up here.
Oh, thank you. Elizabeth, this is a response to a question you had. I'm Jay Nakashima with eHealth Exchange. You asked how many electronic case reports are submitted each year, and it's 80 million. And obviously that will improve or increase as we get more practices in hospitals to submit using this modern modality, and as we modernize public health's ability to receive electronic case reports for more than COVID and MPOX.
Okay, thank you. That's great insight. Let's see, anybody back here, way over there. Yeah.
We got a guy right in the center in the back, too.
Okay.
You want to hold it for me? Wow, I have a professional mic holder for me. I'm so impressed. Hi, I'm Jackie Gerhardt. I'm a Chief Medical Officer at Epic. And I just wanted to double down on something that Mandy said briefly, which was TEFCA. It's an acronym, TEFCA. It stands for Trusted Exchange Framework of the Common Agreement. And why I want to double down on that is because multiple people that have data, including Epic, have joined that as a government standard backed model that is national, which is totally new and novel. And I wanted to answer your question about why we don't exchange data more freely as different public and partnerships. One of the reasons is just the standards aren't there. So one organization needs to say, I'm recording A, and the other organization might be recording B, but they're trying to get the same thing. And so what we really need is just a framework, and we finally have one. We have one. And so it's just we need the different healthcare organizations, the different public and private entities to actually join onto this one. It's backed by the ONC. It's not state-specific. And so that, I think, is going to be the key. It's sort of nerdy and wonky, but I think it's going to be the key to actually getting data where it needs to go. And then my question would be, if that's an answer, what do you think are the barriers to getting organizations to either take that on, understand it? Is it too wonky? What could we do to better communicate? Is there a different way that you would suggest that I'm not aware of?
Well, I'll start with public health. We're putting real money behind it. We're saying, let us help you, states, localities, be the first ones to adopt this. We're going to help you through it. We're going to give you technical assistance, but money as well. And we are actually seeing a lot of interest on the public health side. So I think this is where I need help from Congress to make sure we can continue to fund our public entities to be part of these kinds of systems. And I do think we are solving those technical challenges, but the resources need to be there. We need to also have the expertise and the workforce who knows how to help transforming it there. So that's on the public side. I'll maybe turn to you, Ethan, for the private side.
Yeah, I mean, we're part of the TEFCA movement in FIRE, and I think those standards are really critical. I think some of it comes back to, okay, if I'm a hospital, not United Health Group, I'm a small hospital, and what's my capability of doing this? It's a lot of resources. I can't do my latest Epic upgrade because I'm putting all of my money into this. What do I get back from it? It's that give-get thing that I talked about before. If hospitals or health systems or insurers start to see the benefit, I'm managing a population of millions of people now in my region. This gives me better insight into the better management of that population because I'm getting data from sources that are beyond just my own. Now I'm starting to get into the conversation of value-based care. Now I'm starting to see the economic advantage and the health outcomes advantage of bringing our data together and sharing. So I think when health systems, smaller groups start to see the benefit as they transition to different payment models, that's another carrot for them to get on board. If it's only a give, it's harder for them to make the jump because they have competing priorities.
I just want, we talked earlier about this, and I'm going to look into this more. It's a fascinating thing. My recommendation would be, from a governmental official perspective, is try to keep it as much private sector as possible. And you know, if you start seeing where you have, you know, where you get more, I'm not talking about this, I'm not talking about the CDC, I'm talking about other federal agencies, whatever that may be, and you end up just with a large bureaucratic system, you will find people will not want to participate. So in my personal view, it's great that if this is, I get there's governmental engagement, but you want to, I think if you're going to really do this right and you want large participation, you have to keep this a public-private partnership, but lean more towards private.
Let's see, I think there's a question way in the back.
Yes, Courtney Cash with the World Shoe Fund. In our efforts to fight neglected tropical diseases, we're using footwear as promotion of hygiene, vaccine uptake, incentivizing, and then just fighting STH. We've opened factory in Ghana now with 200 employees as a for-profit venture to build independence, economic development. Like you said, the connection of economic development, generational wealth leads to healthier communities. Mm-hmm. Can you all speak to what the CDC or the U.S. government might be doing in underdeveloped countries to provide independence through public-private partnership, funding, beyond maybe vaccine distribution, to help them have independence in fighting their own diseases?
Yeah. So CDC works extensively globally. We have 60 offices around the country, multiple regional offices, and actually the way we do our work globally is on capacity building. So I was saying earlier this morning, instead of giving folks fish, we teach folks to fish. So instead of building a lab, we teach laboratorians. Instead of maybe building a school of public health with some fancy buildings, we train epidemiologists. We've trained thousands of them in Africa and Asia, all around the world. And so I think there's a lot of work that is ongoing from a capacity building, but it starts from a place of building trust, right? And understanding what are the problems that individual countries and communities want to solve. Sometimes that's focusing on their HIV burden, other times it's malaria, others is just they want to do general capacity building. But our ethos is about partnership with those countries, and certainly a lot of private-public partnership in those spaces, particularly in the laboratory space, the diagnostic space, therapeutic space. So a lot of opportunities globally. I know we didn't get to touch on all of them, but a lot of opportunity internationally.
Well, I think we have run out of time, but please come on up and flood them with your questions. I hope that's all right. But thank you so much. You were all three terrific, and this is really great. Thank you.
Thank you.